Cheers.
Happy Wine Down Wednesday. It needs to be Friday.
Oh, I know. Well, I'm already halfway there. My shoes are off already.
We are halfway there. It's Wednesday.
Yes.
Okay. Oh, we have to let you know these little things in our ear are new mics
mics
from Apple.
So hopefully my hair doesn't make lots of
I
loud
hope we
noises
sound
with it.
okay.
Put him over. It looks great.
Okay.
Put it
all right.
over.
Around.
Oh, I kind of like it. It's very professional.
All right.
Half
Okay.
and half, so it doesn't look like this.
So today's topic, we're going to dive into breast lifts first, and then breast lifts in combination with a breast augmentation. That way, there's just this big need for, I think, further discussion for it.
Clarity, yeah.
Because patients come in all the time and they're either one scared to death to have the scars from a breast lift, or they really want them both done at once and they really probably shouldn't, or there's a couple different scenarios that we'll kind of dive into. One, let's talk first about breast lifts and what makes somebody need a breast lift. That's probably the first place to go.
It's one of the most common questions I get is how do I know if I need a breast lift? And there are certain measurements we can take from the sternal notch to the nipples and from the nipples to the breast fold. And there are some averages, but they really don't tell the whole story.
Right.
And there's two reasons for that. Number one, the amount of sag can be different when you look at the nipple versus the breast tissue itself.
Mm-hmm.
And number two, some people just have a lower set breast. We all have what we call a breast footprint, which is where the breast lives on the chest. And
Yeah.
for some people, it's just lower. So even though they want their breasts higher, they're not going to go there.
When we go into that and explain the footprint in the rooms, it just kind of makes a light go off with patients to understand
and it did
what
for
does
me
a footprint
too when I
mean.
finally learned that concept.
Right, and it's kind of like it tells you the borders of where your breast lies and kind of what borders you shouldn't go out of.
Yeah, so let's look at that first. So this is a diagram of a breast, and the footprint, if I can get the drawing tool, the footprint is everything from where your fold is, and most people's folds are slightly under their breast tissue, but for a perfectly perky, no sag breast, sometimes the fold is legitimately under the breast, but the fold is the bottom of the breast.
Here.
The inner border of the breast is where your cleavage stops when you push your breasts together. There's usually a line.
It's a stopping point.
It's a stopping point. The lateral border of the breast is generally the front of the armpit, but some people have more natural breast tissue on the side. Some people have a breast that ends a little bit before their armpit. And the upper breast border, it's usually somewhere slightly below the armpit. And it's basically where if you push your breast up, that's where you're going to see that crease or that line. There's technically a small amount of breast tissue that goes all the way up to the collarbone, but where we're really limited for a lift is where this bottom border of the breast is, because it's very difficult to actually raise that border up. So that's breast footprint.
I think down
close.
There you go.
Don't say. So now I want to talk about the different types of sag. Before I do that on a technical level, I kind of want to give a couple quick and dirty tips to people who wonder, should I get a breast lift or not? Tip 1, if you do this in front of the mirror all the time, you probably need a breast lift, not implants.
To that one patient today, because she was really on the line of like,
Yeah.
I really don't want these scars, but I really don't know what I want to do. I'm very confused. And we just said, are you going in front of a mirror and lifting? Because if you're lifting, implants aren't going to make miraculously your breast rise up.
No.
That
For
might bring
very
them down.
few people, if they're empty, deflated skin, an implant will
With no
fill
sag.
out that skin. But for people with real breast tissue or who have implants already and want them to be higher, most of the time we're talking about a breast lift. Second thing that could be a clue that you need a breast lift is if you can put a pencil under your breast without a bra on and it stays there, that means you have enough what we call glandular ptosis, meaning there's enough of your breast that's fallen below the breast border, that bottom of the footprint, that it may be worthwhile to get a lift. And the third thing is if somebody says, well, I like my breasts when I do this in the mirror, and raise your arms, that's also a lift.
Yeah.
So now we'll get into kind of the different grades of ptosis, because I talk a lot about ptosis and patients wonder what it is. And when I was a resident, I really remember them talking about 3 grades of ptosis. Grade 1 ptosis is where your nipple is still above the fold.
You can tilt it backwards a little.
Back?
Oh, this way.
Yeah.
Forward.
There
So this is a no sag breast. All of the breast tissues above the bottom border of the breast. The nipple points generally up at 10 to 20 degrees, which is kind of the ideal breast shape and fullness. And about 45% of the volume of the breast is above the nipple, and about 55% of the fullness is below the nipple. Once we get to grade 1 sag, which is what most 20-somethings have who have more than an A cup or so, the nipple is now kind of just at or above the level of the fold, and you start to lose some of that fullness in the upper part of the breast, and it starts to become a little more bottom heavy. Grade 2 is where the nipple is below the fold, and that's generally where the borderline comes in between, can we get a lift by filling things out with an implant versus no, not so much. Grade 3 means the nipple's pointing at the floor, and there is no way to do anything with that breast except lift it unless you want it to
bring
look
it
the
back
same. I've had older ladies say, well, this is natural, this is appropriate for my age, I just want to put an implant in, and one of two things happens. Either the implant volume goes...
here.
Yes, and we can
do
draw
all
that.
Perfect.
Either the implant volume goes way up here, and you get this humpy, long breast.
Snoopy.
Or the implant goes down here, and you get a rock and a sock.
Yeah.
Either way, most people end up not being very happy with that.
Yeah.
The next thing I want to talk about is pseudotosis. Now, this is somebody whose nipple is still well above the fold. And this is actually kind of common for somebody after implants or breast reduction surgery, where a lot of the tissue has fallen below the fold again, but the nipple's in the right place. And really, sometimes an implant can kind of fix that a little bit. But most of the time, you're talking about reducing the amount of skin
between
that
the
covers
nipple
the breast between the nipple and the fold.
Here to here.
And this last one is something it wasn't even on my radar in residency, but I see it so commonly. And it does seem that there are certain heritages, Latin Americans, that have this shape of breast where even though the distance from the nipple to the fold is short enough that it doesn't count measurement-wise as somebody who needs a lift, the nipple is so low on the breast
from here to here
that it will look awkward or wrong if you don't reposition the nipple.
Right.
So these are all the different grades of ptosis, and these are the ones people think about commonly with relation to the nipple, but it's also important to think about what your breast tissue is doing in relation to the fold.
Underneath the nipple.
Yeah.
Right. So I think we can get out of that one and we can go into talking about dun 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 the scars.
Yes.
Because everybody freaks out about scars. They think, oh my gosh, my breasts are going to look awful and horrible with scars. And there's multiple different kinds of scars. There we can kind of go through about different lifts. Because not everybody needs the full anchor, as we call it, scars. They may need just around the areola. I guess dive into that because I think it gets scary because you can kind of see some before and afters of bad scars. And some people just don't scar well. Yeah. And it's a trade-off. Whether you really want really pretty breast in a bathing suit or clothing or things like that, or the scars.
So it's pretty rare to have scars bad enough that you can see them through a thin t-shirt, but it is possible. So if you have keloid scars other places on your body, you may want to think much more seriously about doing a breast lift than somebody who has been cut and operated on and has really very good scars. The periareolar lift, sometimes called a crescent lift or a Benelli lift, they're all sort of versions of the same thing. It means we're really trying to keep all the scarring around the border of the areola. I don't really like to think of that as a breast lift because it doesn't lift any of the breast tissue. It just can move your areola an inch or less up on your chest.
And it can give you really wonky shaped areolas because they don't always heal perfectly circular.
Yes. What I have seen a ton of is what I like to call the Strax breast. And I'm sure other places do it too, and there are some patients that go to Strax who don't get this, but I've seen it 1,000 times. Patients, I'm sure, whatever it's called. Patients will come in having had sag, and they say, oh, my surgeon didn't want to put scars on my breast, so they put in a really big implant and did a lift just around the areola. Well, the more skin you try to remove around the areola with a large implant, number one, you get a bad scar because there's a lot of tension on that scar, and it will tend to spread and get about that wide, and it just tends to look like stretched, thin skin.
Yeah.
And it also flattens the breast. The breast is supposed to have a slightly conical, coney shape.
It flattens the front of it is what she means. Like your nipple and areola area starts to be like almost compressed again.
Smushed.
Yeah, smushed. Look.
Yeah, and the skin is not designed to hold a lot of tension. So it can reposition the areola and nipple, like I said, about an inch or less. But if you're trying to shoot for more than that or trying to hike up the breast tissue with that, you're going to end up with an oblong, stretched out areola. I've seen some women whose areolas were probably closed to be the standard size of about 4 centimeters
stretched.
after surgery, and I've seen them get as big as 9 or 10 centimeters across.
Where they're almost taking over the breast.
Yeah, it's about
literally like
half of
an
the surface
areola.
of the breast, and then if we want to convert that to a regular lift, it's very difficult to get all that areola pigment out and keep the size of the breast that
Now,
patient
I
wants.
know people that I know have voiced concerns about having natural breast and having overlarge areolas just naturally, and you can reduce those down because you're not
Absolutely.
trying to stuff an implant in there with the same time as reducing the areolas. So
Absolutely.
you can get a really pretty areola reduction if there's not a bunch of other moving parts kind of
Right,
going on.
especially if we're lifting only or lifting and reducing the breast. We
Right.
really only see those issues when we're augmenting the breast and kind of trying to stretch the skin at the same time we're trying to make it smaller.
So that goes to the big topic.
Well, we haven't talked about the vertical and the other
Oh, we gotta
lift
go
yet.
to yes.
So we're
that's right.
still on lifts. We talked about periareolar. The vertical lift adds a scar down the front of the breast that allows
There's
us to
that thing.
pinch
You
out
can grab
skin.
that up, 'cause that's
I
on
don't
there.
think you can see the scars
No, not
very
that.
easily.
Not on that one.
No.
She's upside down. Wait,
There's half of
and she's
her.
halfway. Let me get it, because there's a whole diagram. Let me go out, breast lift. Oh, we went back out again.
Well, this is the one that people call either the lollipop scar or, I don't know, it's the vertical scar, or sometimes people call it the circumvertical scar.
I think it's one of these.
It's that one.
That one.
So
There we go.
this is the area of tissue we're really removing.
What the heck?
It might have just
Sorry.
died.
I'm not used to picking this thing up and... No, it's not. It turned off.
Oh. Anyway, the scar would go around the areola because we move it up, and it also goes down the front of the breast to pinch out a little bit of skin side to side. Generally, if you don't have grade 3 ptosis, meaning your nipples are still relatively near your breast fold, and you don't have a lot of extra skin in the up and down direction, that's going to be a good option for you. So people who need just a little bit of a lift, or people who are kind of on the borderline for a lift and don't want an implant,
And this looks scary. Because
Well,
it looks like this is your scar, but it's not.
the
That's
scar.
the opening.
The
That's
scar is this.
Yeah,
and
it's
if
gonna-
you can't see it, I'm going to draw it so it's a little bit darker. It's around the areola and down the front of the breast. And yes, I can do a straighter line with a scalpel than I can do with my finger on an iPad.
yeah. So let's see. Does it go back that way? Oh gosh, doggone it.
I did that before too.
Okay.
So the next lift incorporates not only removal of skin in this
The
direction,
anchor.
but removal of skin in this direction. And people get a little freaked out when they think about that full scar, but very rarely does it go from
Yeah.
fold to fold. Most of the time, it's just a little scar hidden under the crease of the breast once it
Yeah,
settles.
more like. Oops.
Yeah.
doesn't
It's not drawn anymore.
Yeah, you can tilt it too.
Sorry,
There you
this
go.
thing does not.
Most of
weigh
the
a
time,
light
it's a
feather.
slightly shorter scar that's completely hidden beneath the breast once it relaxes a little bit. And the main purpose of doing that is for some patients, when we do this vertical lift, this pinching action can make this scar so long that either the nipple ends up poking out of the bra, or you end up with a scar that goes below your breast fold.
Or what about, let's talk about, like, if somebody just does this vertical here and then avoids this one, it really can kind of distort the shape of the breast too.
Absolutely.
Because then you're now looking more pinched and pointy, and you're losing this natural soft fold that the bottom of the breast is supposed to have.
Yeah, so I try very hard not to ever have the distance from the nipple to the fold be above 9 or 10 centimeters in surgery, because that is really representative of a youthful breast and a C or D cup size. Of course, there are exceptions to that rule,
Right.
but if that distance is longer than that after I've done the vertical, I almost always will incorporate a little bit of horizontal skin excision
Mel, can you
too.
actually see that scar on there?
Kind of, sort of.
Because that's really how it heals over. If they can
Well,
actually see
for
that.
most people.
For most.
If you give it 2 years, most people's scars will heal to a fine skin-colored line that's not more than 1 millimeter or 2 wide. There can be a couple things that happen with scarring. Some people can have what we call hypertrophic scarring, which means it gets thick like a rope, it gets hard and it gets firm. Scar creams can help. Steroid injections can help that type of scarring. And we can always do a surgical revision of scars. There's a lot more tension and tightness on the scars when we're actually doing the breast lift. If we're just revising scars in the office, a lot of times there's less tension on the closure and things will heal better that time around. So I have had some patients where we've just redone the scar and it turns out looking better. For the first couple months after surgery, almost everybody's scars are a little raised and a little pink. But like I said, given a couple of years, over 90% of patients have scars that are pretty imperceptible.
Yeah, sure.
And
Because they're on the web. Okay, so this is one that's healed. And
Tilt
was
down.
a pretty
There you go. Perfect.
major job. So it kind of just showed, oh my good lord, I swear. I give up.
Thumb.
Well, holding this thing, it's not like holding a phone. I feel like it's like the boombox. So she does have some stretch marks over here on the breast, which will kind of stay and be there, but as they were filled out with the implants, it did help them not be so dark and pigmented. But you can talk about, Dr. Goldberg, how the areola incision around here and down, this is not that far out either, actually.
No, I take most of my after pictures between 6 weeks and 12 weeks after surgery. Of course, we have patients that come back after that, but not nearly as many as come in the first couple of months
Biggest
after
thing is seeing where this is from like that diagrams we saw where it's pointing down. And now you can see the nipple positions up. The implant is... Did we have an implant on
No.
her? We didn't have an implant. No. Hard to see from the side. But she... now you can see where the distance from the nipple to the fold. And now the breast is back up in the footprint of where the breast should be.
Yeah. And if you want to know where your nipple should be, there's another little guideline. Halfway down your arm is about where your nipple should line up. So that's, again, why you can't always just cookie cutter say, 18 centimeters, 20 centimeters, because it's very different for different people. And aesthetically, some patients are okay with their implant or breast or nipple being a little lower than ideal.
Right.
Some people are comfortable with that and actually think it looks better and more natural.
Yeah.
So I like to talk to people, too, to figure out whether they do want to strive for that aesthetic ideal or whether their aesthetic goal is slightly different than that ideal breast.
Right. So that kind of does go into, like, when people come in for a breast aug and you kind of go into that section of saying, well, this is where your breasts are, this is where they will be, just fuller. And if it's not so bad that we're like, listen, if you don't do the lift, it just isn't worth it. But then usually the patient says, I really do I like the slope, I like the sag to my breast. Then they're okay with it, but then there's some people who just need it in order to achieve the right result with the implants.
Yeah. And, patients shouldn't feel pressured to make that decision by themselves. I mean, that's why doctors have a lot of experience. And this is one of those surgeries where I feel like a lot of patients do need to go to 2 or 3 or 4 surgeons just to find somebody who they feel really understands what their goals are and what they're looking for.
Right.
And doesn't just give them the surgeon's ideal aesthetic breast.
Right.
Because I've seen a couple of patients come in and they said, well, this is not anything close to what I asked for, but the doctor said, oh, no, you're not going to be happy until I do a double D, and it's just better for you, and you're a bigger gal, and it'll be more proportionate. And
right. And it totally was missing what they wanted, all in all. But,
so about lift and breast aug, because Kim mentioned that a couple times.
It's become more and more a topic of... It can go one way or the other.
Yeah.
And
so when I finished residency, my goal was to just make patients happy. And blissfully naive, I just thought pretty much anybody could get an implant and get a lift at the same time. The further I've gone into practice, the more I realize that either you're going to compromise the lift, because during a breast lift, sometimes we'll actually rearrange the breast tissue internally, which can interrupt some of the blood flow to the nipple. If we're also putting an implant behind it, there is much more risk of having scabbing or loss of the nipple and areola. If we stay on the safe side and don't really rearrange the breast tissue and just reduce the skin to lift the breast, then a lot of times patients will come back and say, well, they've resagged within 3 to 6 months and they're not happy. And I remember this happened with a girl just about 6 months ago where we told her very clearly, we recommend 2 stages. You will be happier with your result if you do the lift first, let everything settle, and then come back and put in an implant. She said, I'm going to do it one way or another with another surgeon. I really want you to do it. Would you please, please, please do it? 3 months later, she was back in asking about how much it would be for a revision. And then you're almost doubling your cost of surgery.
You're doubling your cost, then you're already doubling your downtime. And a lot of patients, that's really where they go. They're like, oh my gosh, ideally this is not what I want. And most of us, we don't want 2 surgeries. You want to get everything done and be done and recover and call it a day. But if you're going to outweigh the risk,
anyway.
You're looking at double the cost, double the downtime. So regardless what surgeon you go to, just make sure you really hear out what the pros and cons are.
Yeah, and it's different for different patients.
Right.
If you have an A or a B cup and it's mostly loose skin and it's kind of deflated, you could do both at the same time pretty much any day.
Yeah.
If you've got a very full B or a C cup or a D cup and you want more fullness on top from an implant, but you also want to lift, your breast tissue is so heavy, it is really going to resag unless we do an aggressive lift, which is just not usually safe to do at the same time as an implant.
A really good thing, because a lot of women want this certain ideal breast, but they maybe already have, so let's put in the scenario, there's a patient who has a D large breast. And they're like, but bringing in pictures of somebody with these tiny perky B's, and they're like, lift my breasts, reduce them, and then make it more implant and not my breast.
Almost like thinking about doing a sort of a mastectomy,
right,
in a sense, and removing a very large amount of breast tissue and putting the implant
right
in.
Because ideally, if you just do a lift and you add the implant, you're not really going to go smaller, you're going to be bigger because you're adding volume and reducing. So in that sense, it's definitely safer to reduce all the breast, make a beautiful lift, make a beautiful breast, and then come back and kind of resize for the size of the implant.
Yeah.
Right?
And again, it depends on the patient. If you've just got a little need for a lift, you can do that at the same time. But if your breasts are down here and they're a D cup and you want them up here with volume, 2 stages is a safer option.
Right. So the other thing was with the implants and lifts. We had one other thing I wanted to talk about. Above or below the muscle, because if a person has enough breast tissue, they can kind of camouflage and limit their downtime. I guess go over that, because that was one thing that a lot of patients we have offered to do, and then they're like, but I thought it has to be underneath the muscle.
So for most patients, I do think below the muscle is a better call. There's lower rates of capsular contracture, especially with smooth implants, and most patients who have a small amount of breast tissue or are pretty thin will have a more natural look and feel to the breast once it's under the muscle. There are some exceptions, though. I have put a few smooth round implants above the muscle. I prefer to still do them below, but if somebody's really on the borderline for a lift and they've got a lot of breast tissue and they're willing to accept a slightly higher risk of capsular contracture, that can be a great plan for them that limits downtime. Personally, if I'm going to put an implant above the muscle, I feel much more comfortable having it be a textured anatomic form stable, otherwise known as the gummy bear implant. Those have been shown to have lower rates of capsular contracture above the muscle.
Just so I can show what that is.
Oh yeah, versus a smooth.
Oh yeah, both. We can kind of show you what these implants are, just to put it a little bit more into a visual.
So that's about the only patient population that I will kind of say, if you're on the borderline for a lift, we could try with an implant and just a periareolar.
So say
if it's
why?
This specific implant. And the reason is this implant has preferential fullness at the bottom, so it tends to push the nipple up and away from the body. It's also textured so it sticks in place and doesn't tend to settle lower on the chest. This implant, that's a round implant, is rounded across the front, so if you've got any kind of nipple sag, it tends to just hang off the front of the implant.
Wants to go with it, with gravity.
And as your breast settles, this is usually going to settle down lower with it too.
And when you move, like also if it's moving inside there, it's just kind of beating and beating and beating.
Yeah,
towards
they call that the water hammer effect, and it can stretch out your capsule over time.
Right. So if you do it under the muscle, then we can pretty much use
any implant.
Yeah. Okay.
Now, I'm not a huge fan of doing an aggressive lift with this implant under the muscle, because as we tighten the skin over the bottom of the breast, it can push this a little higher than we want it, and then it will stick there. These stick in place, and if they stick higher than you want them, you could end up with some laxity of the breast tissue underneath. So I prefer to do this if I'm just doing a very small vertical lift or a periareolar, but not a big lift. And I know there's surgeons who are comfortable doing that, but for me, it just hasn't worked out the best.
Yeah. And I guess the other thing, just kind of, this thing is so weird. I feel like I
don't even notice it anymore until you talk about it
here, and I can't hear out of this ear. I guess the other thing was like people who go to get at a consultation, they probably do need a lift, and then they're like, no, just let's fill it all up with implant. Let's just fill out all your mom, you breastfed. In there, and then someone's just like, let's just fill it all out and we'll call it a day.
That is a year-long solution, basically.
It lasts about 1 year to 2 years, and then you're right back where you started, but now you have a really large breast that's sagging.
Yeah, and there's still loss of fullness at the upper part of the breast, and now there's more heaviness and more tissue hanging over the fold.
Right.
So that is a possibility, again, for patients with a small A cup or B cup.
Oh, yeah, for that, yes.
But anybody that's not the perfect candidate for just filling out loose skin really needs to consider doing a lift. And that's based on measurements and your
that's what
aesthetic
the consultation's for.
Exactly.
Ultimately, why, a lot of people are like, but I think I need a lift. I'm not sure if I need a lift. Well, go to consultations, get opinions, and if you're across the board, every doctor's saying get a lift, it's clear as day you need a lift. But if you get
And
maybe
be wary
one,
of like 4 doctors telling you need a lift and one saying, no, we can do this.
That's when you show some radars going off.
Yeah.
But yeah, I think that's it. That's it for like combinations of breast lift and implants. We didn't really dive into all the implants and augmentations, but we can do that next week.
We can do a little bit of that. We've
Next
talked about
week we
breast
can go
augments,
into like actual breast augmentation and the newer implants that are out and stuff like that just came out over the last year and the different companies. And
yeah, we haven't talked about that yet.
Yeah. Yeah.
All right.
So thank you for joining
Thanks,
us
everybody.
for Wind Down Wednesday.
Cheers.
Enjoy the rest of your Wednesday.